these implants and did a hip graft augmentation here and here. And remaining was one implant that you can see and you use as a reference point as to what will happen after this point. During the second surgery, the surgeon placed root forms in this area here, but you can see that the base bone right here is at the same level as it was before, and the hip graft bone here is missing. There is additional bone here in the sinus that remained after the hip graft. Over on the other side, this hip graft completely failed, and you can see the original implant that wasn't removed from the original implant is still here, and you can see the bone level here has not changed at all. There is some indication of hip graft here. So the surgeon added more bone to this area, and then this x-ray over here represents implants placed into the bone, and you see the second hip graft did not take as well, and there is some hip graft here left that the surgeon placed implants, but the level here has not changed from the original surgery. Here's a comparison of the original implants with the bone level at this point here, and then after 2 surgeries and probably 2 years later, this is the amount of bone this surgeon was able to get, which is not very much more than what the patient had originally. So this patient paid the price of 2 more hip grafts, about 2 years more worth of surgery, and essentially gained maybe 1 or 2 additional implants.
Preparation for surgery. The surgery needed for a direct bone impression and the surgery for insertion of an implant made from a CAT scan generative model are exactly the same. Direct bone impression requires 2 surgeries, one for the impression and a second for insertion of the implant. A CAT scan generated custom endosteal implant requires only 1 surgery. So as not to be redundant, we're only going to describe one surgery procedure. And before we do that, I want to describe how to make a CAT scan generated implant and how to make a transfer template. And then we're going to do a direct bone impression and then show an insertion procedure. The CAT scan model technique: making a CAT scan jig, trying in a CAT scan jig, cutting the crossover notches, making a transfer template, designing the maxillary endosteal implant, and the finished implant. A CAT scan jig is made from base plates that are tried into the mouth. Vertical dimension at rest is determined, the bite is registered, and is transferred to an articulator. These are 3 different views of a CAT scan jig. They're light and they're comfortable for the patient, and they orient the jaw in a comfortable vertical dimension at rest. Here's one tried into the patient's mouth, and when the patient closes down and their lips are relaxed, the lips just barely touch. And you can see the hole for the tongue, and also so the patient can breathe through their mouth if they wish, and it just makes it more comfortable for the patient. The CAT scan model is produced using a clear laser preliminary resin. The sites for the crossover struts are selected. Notice the sinus are in clear view and can be avoided. Anywhere from 4 to 6 abutments can be designed with these implants, but the vast majority of cases only use 4 abutments. Surgical transfer template is constructed over the CAT scan model using a light cured resin. This template is used to transfer the exact location of the notches to the patient's maxilla. The surgical transfer template is trimmed and polished. The transfer template and underlying CAT scan model are cut with an acrylic laboratory burr to form the crossover notches in the CAT scan model. The CAT scan model now has the crossover notches cut into it. This transfer template is used to transfer the exact position and shape of the crossover notches to the patient's maxilla. The design is marked onto the CAT scan model. The completed maxillary subperiosteal implant is tried onto the model before sending it out for HA coating.
The surgical procedure.
The direct bone impression.
This surgery is the first of 2 surgeries needed for a direct bone impression. Both surgeries needed for the direct bone impression are exactly the same. CAT scan generated implant delivery surgery is exactly the same as for the direct bone impression. Step-by-step procedures for the direct bone impression technique. Incision, flaps, suturing tissue away from the surgical field, impression, suturing. Combination syndrome with massive destruction of upper bony ridge. This patient, when you palpate the upper maxillary ridge, is very knife edge, very thin. No way that you can get root form implants into this patient. The incision is carried from the distal of the tuberosity on the right to the contralateral tuberosity on the left. The incision starts with the upper left, and we're angling the blade toward the buccal so that we can have maximum amount of palatal tissue to suture the implant to. Since the palatal tissue is not mobile and it can't be moved, we want to have as much of the palatal tissue as we possibly can. Now we're moving to the right tuberosity, again angling the blade toward the buccal and trying to have the tip on the crest of the alveolar ridge and moving along toward the midline. Now we're cutting the midline relieving incision starting at the nasal spine and connecting it to the incision at the midline. The posterior right relieving incision is in the posterior lateral part of the tuberosity. The left releasing incision is done again contralaterally along the posterior lateral part of the tuberosity. Flap procedure. A full thickness flap is elevated beginning at the midline and extending it to the distal extent of the tuberosity. As we're reflecting the full thickness flap, sometimes the flap will go very easily and sometimes it's bound down very tightly with connective tissue. But we move along trying to get as clean a dissection as possible. We'd like to get the periosteum off the bone as clean as we can so that the membrane isn't damaged, because we're going to be using some of the cells on that membrane to begin to grow bone between the alveolar ridge and the periosteum. The theory is that we're going to sandwich the implant between two osteogenic structures, namely the alveolar ridge and the periosteum. We feel the osseous integration is greatly enhanced by placing the sub between these two structures. This enhances bone growth and to totally engulf this implant in solid bone. Handling the incisal foramen. The incisal foramen with the nasal palatine nerve is isolated in size. No bleeding ever occurs when cutting this bundle. We were taught in general anatomy that the nasal palatine bundle contains an artery and nerve, but in the years that I've been doing this procedure and cut this on many hundreds of times, I've never seen this bundle bleed. Suturing the flaps away from the surgical field. The palatal tissue is tied away from the surgical field by pulling it into a purse string. The buccal flaps are sutured to the cheeks. The bone is curetted clean of tissue tags in preparation for the impression. Moist 2x2 gauze is tucked under the flaps both on the buccal and palatal for hemostasis. The gloves of the assistant mixing the impression material is washed free of talcum powder. A sock tray is sterilized, the impression material is measured, the operator then incorporates into a homogeneous mix as rapidly as possible. A hot dog shaped portion is then placed into a stock tray and set aside. The moist gauze is then removed. Small portions of impression